common sense drug.
American, young, old, rich, poor.
I'm Judy Strand, and on behalf of the Commission for Senior Services, I welcome you to this great event, the first ever Oregon White House Conference on Aging. Thank you for being here. I'm really honored to represent the Governor's Commission. It is a vital voice of advocacy for all Oregonians, and I'd like to thank each and every one of you for the ideas that you're going to bring forward today that are going to inform our nation. I also want to make some special acknowledgments of the sponsors and contributors for today's event. Samaritan Health and the Conference Center staff, the Medicaid Long-Term Care Quality and Reimbursement Advisory Council, AARP Oregon, the Oregon Department of Veterans Affairs, the Oregon Association of Area Agencies on Aging, CCTV Salem, Albany Volunteer Caregivers, and our fantastic conference planning committee. I also need to acknowledge Ann McQueen, who staffed this conference, and I would like her to be identified. Where is Ann? Where is she? There she is. So this would not happen without her, and I want all of you to know that. Believe me, we couldn't have done it. So great gratitude there. I wanted to start by acknowledging the fact that many of our cultures, especially our indigenous cultures, value elders in a way that is exemplary, and that many of our immigrant communities that now live in Oregon are showing us that same example. However, I believe that our dominant culture has not yet caught on, and I think that that has prompted a number of comments from a number of aging advocates. One is Gloria Steinem, who said, "At my age, people often ask me if I'm passing the torch. I explain that I'm keeping my torch, thank you very much, and I'm using it to light the torches of others. Because only if each of us has a torch will there be enough light." So in light of all of that, I wanted to think a little bit about what we're focusing on today. In Seattle at the regional conference, which a few of us had a chance to attend, we talked about a lot of important things: economic security, underpaid caregiver staff, absence of culturally specific and culturally responsive aging, lack of mental health services, lack of geriatric specialists, inadequate transportation, all kinds of issues that all of you know better than I do. And all of those are incredibly important. At the same time, we know that in Oregon, we've been a state with some innovative ideas. We've stepped forward in prevention and community-based care and person-centered practice in a very bold way, and I know that we'll do that again today, and that's why we want to hear your voices. I also would like to challenge us to think beyond just looking at the needs one by one and look at the interconnectedness of the needs and what that might bring to our minds in terms of a creative solution for this growing population of older adults. And what if we looked at the ways we can capitalize on the age wave and view that 1 in 5 of us who will be 65 and older by 2030 as a true untapped resource for our community as a whole? A few years back, I was 15. It was 1971. I heard about Maggie Kuhn, who we know started the Gray Panther movement. And she was really of great interest to me at that time, and I wrote her a letter. And of all things, she wrote back to me. I found her letter recently in my family's home when I was cleaning out the home. And in that letter, she encouraged me to be an advocate and fight ageism. She was, for me, one of those lights, one of those torches. And there was something that I'm sure one of you sent me recently that talked about what older adults could be for us in our society. And Maggie Kuhn said that as risk takers, older adults can change the world. They can humanize society. They have 5 roles that she talked about. They are mentors who teach the young, mediators who resolve civil, racial, and intergenerational conflict, monitors of public bodies who serve as watchdogs of City Hall and Congress, mobilizers of social change, and motivators of a society who urge people away from self-interest and toward public good. Our world desperately needs those 5 roles. And think of it. Think of all the conflicts, the intercultural conflicts, the global issues that affect our planet. This is the time to bring our elders into the public square. And I know when I talk about them, the older adults, I'm looking at a room where we understand that they is we, because we want that place when it's our time to humanize and heal the world. And I hope that today we'll come up with some fantastic ways to do that. Okay, so getting to the nitty-gritty, you have these lovely green folders, and as we go forward, they will guide you, and they are color-coded in everything. So in here, you will see the agenda, you'll see a number of pieces of paper on the right. There are issue brief sheets that are color-coded by each issue that we're talking about today, and that will help give you a little background information. And there are some conference evaluations that are purple, and we really would love to have your feedback about how we're doing with this conference today. So I'd now like to introduce Marty Cahill, the Samaritan Lebanon Community Hospital CEO. Since 2013, Marty has been Chief Operations Officer of Samaritan Lebanon Community Hospital and has served as the CEO at Samaritan North Lincoln Hospital and Director of Physician Relations for Samaritan Health Services. We're very thankful for this lovely conference space. So, Marty?
Good morning, everyone, and welcome. This is a great event. Thank you for your participation, and welcome to our event center. We've literally, in the last 2 weeks, opened our hotel. We've got this event center for the last year, so we're starting to utilize it. So let us know how it goes. Give us feedback. We would greatly appreciate that. Again, I'd like to thank you for your participation, the coordinators for this event. I think that your help today will be useful in directing policy and direction for the next 10 years. Some of the things that you're going to be talking about and hearing about today: retirement security, healthy aging, long-term services and supports, and elder justice. And I think together we can all build healthier communities, and I believe that the work here today will be heard back in DC by this summer. So I wish you well. If you have time, there's a jam-packed agenda for you today. But if you can get out and take a look at the garden, there's a Japanese healing garden right next to this facility, nice koi pond. So go out and relax a little bit in between your sessions. Have a good day and welcome. Thank you.
I'd now like to introduce Danny Ledesma from Governor Kate Brown's office. Danny is the governor's Housing and Human Services Policy Advisor, and prior to coming to the governor's office, she served as the Director of Equity, Policy, and Communications at the City of Portland's Housing Bureau. Danny?
Hi, good to see you. Good morning, everyone. On behalf of our Governor, Kate Brown, we'd like to welcome you and thank you for all the work that you're going to do today and that you do every day on behalf of older adults so that to ensure their safety, that they're financially secure, and that their needs are being met. As you know, our communities are stronger, they can thrive when the outcome of the work that you are doing is fulfilled. And as you know, our governor is a strong supporter and champion of the work that you do, and is here to stand shoulder to shoulder with you as we contend with some of the issues that face older adults. So today, as you contend with and discuss and come up with the best and possible ideas around policy change impacting retirement security, healthy aging, elder justice, and long-term supports and services for older Americans, we're really looking forward to the outcome of these conversations that you're having and also how we can support that moving forward. We'd like to thank our hosts that are here, today, all of the keynote speakers and panelists for sharing your wisdom and information with us. And we'd really like to thank the Governor's Commission on Senior Services for your service, that your ongoing service and commitment to this issue. We'd like to thank our chair, Judy Strand, and what the governor would like to make sure that you all know is that we're ready to work with you. We've got really strong leaders at the state. Our DHS director, Erin Kelly-Seal, to work with you, and we look forward to continuing this important work. So thank you.
Thanks, Danny. We now get to hear from Erin Kelly-Seal, the director of the Oregon Department of Human Services. Erin started as the director in April of 2011, and she's done a lot of work in safety and protective service and health outcomes for older adults and people with disabilities. And she's been a very strong support to the commission as well, and we're really happy to have her as a leader in our state. So where are you there?
Trying to be quick.
You're being very
Keep
quick.
us on time.
Oops,
Oops,
there
sorry,
you go.
Judy. Good morning, everyone. All right, come on, Oregon. Let's have some energy here for our federal partners who want to hear from us. This is an amazing opportunity for us here in Oregon. Thank you for that and for bringing the conference here to Lebanon, of all places. Thank you for driving through the farmlands to be here. I'm sure many of you were wondering, as was I, if we were headed in the right direction as we came to this beautiful site, but I'm glad you all made it. It's amazing to think that a conference in Lebanon can sell out in a matter of days, hours, weeks, and that we have a full house, and I'm excited about the energy and insight and intellect that's in the room today, so thank you for being here. In Oregon, we can't help but take pride in all that we've accomplished on behalf of older adults that happen to reside here who decide to come here because of how fantastic a place it is to live. We should be really proud. We had some pioneering efforts that came decades before us, who set the bar really high in terms of a vision for our state around what it should look like to age, both in terms of health and healthy environments and places that we want to be able to live, and also in terms of a long-term care system that supports people to live at home and in community, and with choice and with dignity and with independence. And those are values and a vision that we hold very true and fast in our hearts, and we should. When I go around and I meet with the different staff who do the work on behalf of our agency and on behalf of all of you, I always ask them, so what's going well and what's keeping you up at night? So I thought I would talk about a few things that are relevant to today's discussion that I think are going well here in Oregon, and a couple of things that keep us up at night that we're looking forward to you all having some conversation about today. So what's going well here in Oregon? In terms of the seniors in the state who are low income, it's extraordinary that 87% of them get to remain at home or living in community settings. We can boast of that fact here in Oregon, and we should, because those values that I talked about have really driven a system that supports individual plans for people that allow them to be able to live with dignity, choice, and independence in whatever way is best for them at the right place at the right time. We've accomplished much in that regard, and it's been a lot of hard work, and a lot of you in this room are part of that, and I appreciate it. We also feel good about our third in the nation ranking around several things. I'm going to read them because I won't get them all right unless I do, but affordability, access, choice of setting and provider, support for family caregivers, and effective transitions. That's quite a list, and we're proud to be third in the country. We'd love to be first, though, right? So let's talk about a couple things that keep us up at night that we need to keep working on together. And I will say, others today are here to impart their wisdom upon us. One of the jokes is some of the first people who speak know the least, so I'll just throw that out there for you, but here you go. So one of the things that keeps me up is that women and people of color tend to have the least saved for retirement. And even beyond that, 48% of all Oregonians will rely only on Social Security for their retirement savings. That will afford them to live with about $12,000 a year of income. Oregon ranks in the top 5 states in the country for hunger and food insecurity among older adults. 1 in 3 Oregonians age 65 plus fall every year, with 20 to 30% of those falls resulting in bruises, hip fractures, and traumatic brain injury, which ultimately compromises the ability to live independently. Health disparities among people of color in this state remain stubbornly high, and access to care in rural and frontier Oregon is exceedingly difficult, especially for specialty care like gerontology and mental health. We screened over 35,000 abuse and neglect reports in 2013, And we saw nearly a 40% increase in substantiated abuse involving older adults that live at home or in community settings. Oregon seniors and people with disabilities are estimated to have lost over $11.5 million in savings and equity in 2013 as a result of financial exploitation. We clearly have work to do. That's why you're all here. Just 2 years ago, my grandfather, at the age of 92, passed away in an assisted living facility here in Oregon. He was an amazing individual who greatly influenced my life. He survived abuse as a child, the Great Depression, a mental health challenge that threatened his career as an educator, but he taught me many, many things, many important things, like how to waltz and to polka, how to drive a tractor, how to bake, how to garden. But some of the most important things he taught me were these, and I think you're going to apply them today to the work. People can do anything if they put their minds to it. In my case, around the time of potty training, that looks like this with my grandfather. Papa, I need to go potty. Mind you, I'm not potty trained yet. Well, then why don't you just go? You know where the toilet is. Okay, so I did. My mom says I was potty trained after that. So people can do anything if you put your mind to it. We are put here on this earth not for the good of ourselves, but for the good of others. Hard work pays off. So as you put your minds to some of the most pressing challenges here today of our time, you will be asked to set aside what might be in your own personal best interest for the good of our nation, for the good of all Oregonians. And it's abundantly clear that the hard work that you do will make a difference in the lives of many, many people following the outcome of today and the recommendations, setting the course for the next decades of change and innovation and pioneering spirit that we need to have around some of the challenges we're facing now.
Thank you all. I'm now going to introduce Dr. Erwin Tan, the moderator for the Healthy Aging Panel. He has done so many things. Dr. Tan oversees RSVP, Foster Grandparent Program, and the Senior Companion Program. And he is a board-certified internist and geriatrician. And he previously served as an assistant professor of medicine at the Johns Hopkins School of Medicine, where he was an attending physician in the Division of Geriatric Medicine. He was also a White House Fellow in 2003 to 2004. And served as a special assistant to the Secretary of Veterans Affairs. He also worked on bioterrorism work group at the Department of Public Health in San Francisco. And I also happen to know he's a great father. I had a chance to meet him at a think tank looking at creative intergenerational approaches, and I learned a lot about his personal commitment. So I give you Dr. Tan.
Thank you so much for that warm welcome. The other thing I want to add about my own personal history is that I know Oregon through my wife, who was born in Troutdale, grew up in places such as Salem, Brighton Bush, and Corvallis, and went to school at the University of Oregon. So I know this city, this state well. I know it's a great place to grow up, and after today, it'll be a great place to become an older adult. So thank you very much. I also want to thank Samaritan for being one of our Senior Companion grantees. Their program engages Americans 55 and older in service to other older adults, and to the Oregon Cascade West Council of Governments, which is an RSVP grantee. And they engage Americans 55 and older in a wide range of volunteer activities. But as a father of two, you know that you're not supposed to have a favorite child. But this year is also the 50th anniversary of the Foster Grandparent Program. So on birthdays, you can celebrate one specific child. And I want to talk about the Foster Grandparent Program because that's how I, as a geriatrician, first actually got into this issue of national service. And foster grandparents engage Americans 55 and older who are low income. They receive a small stipend. And what they offer is something very unique. We have in our schools many different programs, teachers, principals, engaged parents. But one of my volunteers who was in an inner city school once had a third grader who was giving him some lip. And he said, "Son, I know your grandfather." And then he showed up at the grandfather's house and the boy was there. And the boy's eyes were as wide as saucers. Two things. First, the game was up, but this boy also knew that Mr. M was someone, and his grandfather knew Mr. M, so he could tell his friends that my grandfather knows Mr. M. And that was something to be proud of. So that's what I believe when we talked about earlier, Dr. Thomas talking about responsibility of being an elder, that's what we have to offer. So when we talk about a silver tsunami, I actually see a silver toolbox. And what's good not only for our individual older adults is actually good for us as society in terms of the health benefits of volunteering and the benefits that you can provide to your community. At Johns Hopkins, we studied such things as, well, we know that Tai Chi is good for your health, but when you're in a kindergarten classroom, there are these rapidly moving objects across your path that cause you to stop. The objects are called kindergartners, and you have to sit down in their chairs, you have to practice your quadriceps, you have to cross the midline. You're then also engaged with teaching them, and anyone who's worked with with teaching or actually reading to a child, Fox and Socks, Llama Llama Red Pajama. It's not the easiest thing in the world, but it exercises your brain. And finally, as one of my volunteers said, volunteering keeps me one step ahead of loneliness. And we know that loneliness is an independent risk factor for morbidity and mortality. So as I introduce my fellow panelists, I want to ask them all to think about also how we can use the resources of older adults to address not only the problems that they address on a daily basis, but also to potentially improve the health of our volunteers as well. So I'm going to start with Dave Toler. Dave Toler has been the Director of Senior and Disability Services for Rogue Valley Council of Governments for almost 3 years. Dave has been in the public and nonprofit leadership for nearly 20 years, including at-risk youth programs, elementary education, and community action programs. Dave has also served in the elected office for 14 years, including the Three Rivers School Board and the Josephine County Commissioner. Dave currently resides near Jacksonville, Oregon, in a 100-year-old home where he spends much of his time with his significant other working on the property. Dave has also been an avid yoga enthusiast for 20 years, enjoys softball, hiking, and billiards. Dave, Mr. Toler?
Thank you very much. So at Rogue Valley Council of Governments, healthy aging is a very important dimension of what we do. And I think I want to borrow from Dr. Thomas's quote earlier this morning that I really appreciated. I think we've really approached our mission in terms of healthy aging. I like that quote of disrupting the conventional wisdom. And I think that's something that really needs to happen in terms of really accomplishing healthy aging. So I'm going to talk a little bit about our Living Well program. I think we've got some slides here. I'm told I can just push these and magic will happen. We'll see if that... Okay, very good. So I'm going to talk about one of our evidence-based programs, which is Living Well. And what we've seen in terms of the healthcare system is two really critical traditional roles that have been played in the healthcare systems. You have the doers, which are the docs and the nurses, providing that critical role of actually providing the health care for our consumers. Then there's the education role that the nurses and the discharge planners and different elements of the healthcare system play and do a good job at. But we have felt that there's been one critical piece missing in the success of healthy aging, and that is the consumer. And that's really the focal point of the Living Well. So I know I don't have a lot of time, but I just want to kind of draw that broad brush of that's the success and the power of the Living Well program. It's a facilitator role. It's really about empowering the consumer. So as you can see there, we've developed all the Living Well programs that there are with chronic conditions. There's a Living Well with diabetes and with chronic pain, and we've developed both of the Spanish speaking versions as well in our community. And did that switch over? Very good. All right. So I'm going to skip through this slide because I don't think I really have enough time. Basically, bottom line to this slide is that our workshop schedules in our two-county area have increased vastly in our community. We've more than doubled the opportunity in our area for Living Well. So I want to talk a little bit about how we've been able to do that. First of all is the tremendous partnerships we have both in the healthcare and other community organizations as well. But the real key has been our partnership with the coordinated care organizations. We have contracts with all 3 CCOs, and the graph there on the right shows you that we've more than doubled participation folks in living well in our area this year from where we were. It's a program that was on the verge of dying on the vine and is now a very robust program that is really serving a lot of folks. So we anticipate those numbers to increase further. And I'll just get a little bit into the program outcomes here for you, because that's the bottom line. That's what we want to see, right? And what this shows you is just a tremendous increase from 40% when people come into that program to over 80% in self-confidence of how to manage their conditions. And that's the power of living well, and we think that's the power, the piece that's been missing in terms of the healthcare system for our population is we've got to get the consumer involved. It's what we've been doing for 30 to 40 years, that person-centered approach, and trying to get that into the healthcare system as well really depends on a strong partnership, and that's what we've been building in our community, and we're really happy to see our consumers. It's a prevention program like many of our other evidence-based, and that's the other piece that's really been missing in the healthcare system, and in our opinion is that lack of focus on prevention. It's been a real challenge to get this relationship set up with the CCOs. It's taken a lot of persistence, some would call stubbornness probably on my part to do that, always being at the door knocking and waiting to engage with them to provide these programs. But we've got a set of evidence-based programs now, about 4 or 5, that we have contracts with all the CCOs to provide these. And in every case, the key in the success to all of these programs is the person-centered. It's what we do best. So thank you.
Thank you very much. Oh, okay, I apologize. Okay. The next panelist will be Carolyn Mendez-Luck. She is an assistant professor for the College of Public Health and Human Sciences at Oregon State University. She completed her PhD and Master's of Public Health degrees at the University of California, Los Angeles, and a postdoctoral at the Veterans Administration's Health Services Research and Development Center for the study of healthcare provider behavior in Sepulveda, California. She is also a faculty associate with the UCLA Center of Health and Policy Research. Dr. Mendez-Luck's research addresses age-relating health disparities and long-term care. Her research examines the social and cultural factors associated with caregiving and diabetes in Mexican origin families and the characteristics of nursing facilities in Oregon. One long-term goal of Dr. Mendez-Luck's research program is to link individual health to family health by designing culturally relevant programs aimed at improving diabetes management in the home. Thank you.
I was hoping to sit down, like Dave. Okay. So if I keep going, will it? Okay, great. Well, it's a pleasure to be here with all of you today, and so I want to quote the words of Rosalind Carter in 1995. She said, "There are only 4 kinds of people in the world: those who have been caregivers, those who are currently caregivers, those who will be caregivers, and those who will need caregivers." So essentially, caregiving touches everybody at one point or another in our lives. I shouldn't have had that caffeinated coffee this morning. I usually drink decaf, so I can kind of feel it like bubbling up here. Okay, but we're all friends, right? Anyway, so I think as it was mentioned earlier that families are the backbone of long-term care in the U.S. There are millions of people who provide care to family, friends, neighbors, co-workers. They provide millions of hours of care every year at a value of at least $450 billion. So if you equate that, like what does that mean? It's almost the same as the total sales of Walmart and close to the gross domestic product of Belgium, which has the 20th largest economy in the world. So when we think of caregiving, we know it's hard work, it's physically demanding, it can be emotionally draining and tiring, and there are a lot of challenges for caregivers that over time may take a toll on them. So there's been a lot of research on caregiving, but in the most recent years, like I'm going to say last 15 years or so, there's been more research being done in diverse communities to look at whether or not, the caregiving experience might be different for caregivers in racial ethnic populations compared to Caucasian populations. And so what this slide shows is that Hispanic and African American caregivers more of them report a higher level of burden compared to Asian American and non-Hispanic white caregivers. And why that's important is because we know that burden is associated with poor health. So I think this was mentioned earlier, that our older adult population is becoming more diverse in the US. And this is just a pictorial representation of that diversity. So I'm not going to spend a lot of time on that. I think we covered that pretty well earlier. So then I want to move to what can we do? So we know that caregiving is hard work, and with the increasing diversity that we will see among caregivers in our nation, that we really need to think about ways that we can be supportive of all caregivers, but pay particular attention to the needs of ethnic and racial minority caregivers. So when we think about the support programs that we might have, we'll need to consider what can we do to provide programs that are relevant for diverse communities. I think a one-size-fits-all approach is not going to be very effective. I know for me that if I try something on that says one size fits all, not everything looks so good on me, right? So what might work in one community may not work in another. There's also been an interest in adding caregiver assessments to older adult assessments for programs that are particular for older adults, and also in healthcare provider visits. So what that would do is not only identify the needs of the older adult and perhaps where there might be some unmet needs in terms of their day-to-day care, but also to identify needs of the caregivers, and perhaps most importantly, to identify those caregivers who are at greatest risk for burnout or for other health problems. So there's been a study that looked at these caregiver assessments being incorporated into some older adult programs, and a study found that of 30 states, that there were only 30 states, or 30% of states, that had Medicaid waivers for home and community-based services programs, actually had these kinds of assessments in their client assessment tools. Oregon is not one of those states, okay? So we have a ways to go there. And then lastly, I'll say that we need to provide more training and education for caregivers, and I think that was talked about earlier by Nora. So I'll stop now. Thank you.
Okay. So Lauren Fontanarosa, is that? Oh, sorry. Laura Fontanarosa has a master's in public health and has served as the program coordinator for SAGE Metro Portland since 2011. SAGE, Services and Advocacy for GLBT Elders, Metro Portland, creates community and enhances the lives of LGBT older adults through advocacy, education, and support. Lauren is responsible for training services and care providers to provide culturally competent care, to the oversight of the release of the Guide to LGBT-Friendly Senior Housing in Oregon, and administering many of the program's offerings of the SAGE Metro Portland. Prior to her work with SAGE Metro Portland, she worked at the Oregon State University as a researcher in the field of HIV prevention. Lauren?
Good morning, everybody. So in my brief time here, I'm going to definitely touch upon some themes that have already been brought up this morning around person-centered planning and ways in which Oregon can really lead the charge in innovation and aging. So I sort of want to divide my brief time here with two pieces. One is kind of the facts and figures about the health disparities facing LGBT, lesbian, gay, bisexual, and transgender elders. And then second, what we can do as advocates and policymakers and service providers to really change the landscape for them. So, if I find my place. So LGBT older adults deal with significant health disparities across areas related to physical and mental health. So these are things including high blood pressure, cholesterol, diabetes, heart disease, HIV, AIDS, and more. This is all combined with the fact that LGBT elders often delay seeking care due to fear of discrimination, and so often aren't seeking care until a crisis hits. And as we've talked about the importance of prevention and keeping people healthy, this is obviously not ideal. Another big, is that, okay. I wonder if I'm, okay, I don't have slides, so you can just look down here. So another huge area of concern for all people aging, but especially for the LGBT community, is social isolation. LGBT older adults report higher rates of loneliness, depression, and they have higher rates of suicide, especially amongst transgender older adults. LGBT older adults deal with stigma and a lifetime of discrimination contributing to social isolation, and also are much more likely to live alone, as other people were mentioning before, that impacting social isolation. LGBT older people are twice as likely to live alone, twice as likely to be single, and 3 to 4 times less likely to have children, and more likely to be estranged from their biological families. So we can see not only how they can become more isolated, but also when we're thinking about issues of caregiving, how often our traditional sort of supports we think about for caregiving are not an option for LGBT community members. But the second part that I really want to talk about is what we can do about it. Being who you are and being able to express that to those around you is really one of the first steps to healthy aging. So it's up to us as a community of advocates and policymakers to make this happen. It's up to us to create a culture where people are free to share their sexual orientation or gender identity and not face shame, isolation, or discrimination. It's up to us to challenge the notion that I don't need to know this about somebody because I provide a high level of care to everyone. I hear this quite often, but by treating everybody as if they're the same, we're silencing marginalized groups, whether it be LGBT people or other minority groups. But by opening up this conversation to people that we're interacting with or providing services to, we get to really know a person and know how to care for them. We can learn about discrimination they've faced through their life. We know about the health disparities that they're dealing with. We can learn about their culture that they came from, and then how to connect them to culturally appropriate resources and social support. So by knowing someone's sexual orientation or gender identity, you provide a much higher level of care. So I urge us to talk about these topics that sometimes we can feel nervous talking about, or we sometimes think it's such a private thing, I don't want to broach that. Far too many LGBT older adults are closeted. A recent study found that almost 80% of LGBT older adults are not out about their sexual orientation in their housing or long-term care setting. 80%. 40% of LGBT older adults say their healthcare providers don't know about their sexual orientation, and 65% of transgender older adults fear that they will experience limited access to healthcare as they age. So I also want to share 2 really exciting developments that have happened across the country just within the past few weeks. In April, San Francisco passed a city ordinance, which is the LGBT Senior Long-Term Care Facilities Bill of Rights Ordinance. So what this means is it will prohibit discrimination against LGBT residents by long-term care facilities. And it's a quite thought out city ordinance, and I won't go into all the details. You can find it online quite easily. But it does require staff training, which is important. It requires, bans the option to discriminate against somebody about their HIV status or sexual orientation or gender identity. It talks about things like if two residents request to share a room together, that they will be allowed. And it also outlines ways that staff should interact with transgender residents around using pronoun of choice. And then just last Friday, New York announced plans for a new public-private partnership aimed at improving healthcare services for transgender people in the state. This initiative was launched by the New York Attorney General's Office, Greater New York Hospital Association, Mount Sinai Health Systems, and Lambda Legal. And what this does is it provides information and training to hospitals about both legal requirements and best practices when working with transgender patients, and really talks about the healthcare needs of this population, which is not something that we've had enough conversations about. So these are just two examples and ways I think that Oregon can really follow suit and really provide some sort of innovation plan around the LGBT community. And really creates a culture of aging where LGBT older adults never have to go back in the closet, and as a result, have a greater likelihood to age with health and dignity. Thank you.
So next I want to introduce Margaret Neal. She is the director of the Institute on Aging and a professor of community health at Portland State University. She teaches graduate courses in gerontology and data collection methods and leads a service learning program to Nicaragua involving working with older adults. Her research has focused on the creation of age-friendly communities, transportation, neighborhood design for healthy aging, older workers, global aging issues, and challenges and opportunities of both managing both paid employment and informal care to elders. And Dr. Neal obtained her graduate degree in urban studies, specializing in gerontology and research methods from Portland State University, and her bachelor's degree in Spanish from Indiana University. Thank you.
Thanks, it's great to be here today. As we think about this topic of healthy aging, how we age is influenced by a number of factors. It's influenced by the choices we make as individuals, whether those are healthy choices or not so healthy choices or downright unhealthy choices. We're also influenced by our genetic background, what we inherit from our parents. We're influenced by our exposures. Do we have healthy environments? Are we exposed to toxins, air pollution, water pollution, those kinds of things? And we're influenced by where we live. So this idea of place really matters. Place matters. So a model for thinking about how we age and how we can all have a healthy old age has been developed by the World Health Organization and its active aging model, which it takes a very holistic view of how we can be healthy as individuals. And it involves, to a very large extent, where we live and the community that we create, the communities that we build. So the World Health Organization, based on its active age-friendly, or its active aging model, created a model for age-friendly cities and communities, which has domains that address the physical environment, the social environment, and the service environment. Portland was the only US city, so 33 cities in 22 countries, to participate in the World Health Organization's Global Age-Friendly Cities project. And what that entailed back in 2006 was doing an assessment of the city's age friendliness in terms of all of those different domains. A few years later, the World Health Organization created a global network of age-friendly cities because there was a lot of interest in not just cities, but also rural communities from around the world on how they could become more age-friendly. And so I've been using this term age-friendly. An age-friendly city or community is one that's enabling, it's inclusive, and it's a community that is friendly for people of all ages and abilities. So the World Health, or the WHO Global Network involves first, to be a member, involves first doing this baseline assessment of age friendliness, then getting your top community official to write a letter committing to becoming more age-friendly, and then having an action plan created, and then monitoring whether or not the implementation of that plan, monitoring whether you're successful or not. So it's a continuous improvement cycle. AARP, I would just want to mention, has recently come out just this last month with a livability index that you can use to evaluate any community here in Oregon, throughout the US. And you get there by going to aarp.org/livability index if you're curious about how your community stacks up. And it's a great way to begin thinking about where are the areas that your community could improve. Where are you good? Where could your community improve? So thinking about the physical environment, we're talking about buildings and parks. We're talking about how we arrange transportation, our housing options. We're also talking about our social environment. Are we acknowledging, embracing all generations? I like to think of it as an interdependence rather than independence. State of Oregon has its 3 core values of choice, dignity, and independence. And I would challenge us to think maybe about changing that independence word to interdependence. And then there's the fact that we need to create opportunities for older adults to contribute. So older adults are the only growing natural resource that we have. And we don't take adequate advantage of all of the skills and talents that older adults can contribute to our society. And moving forward in an era of decreased resources, we need to use all of the resources that we have. So a final challenge that I would like us to think about during the day is what communities in our state could work toward becoming more age-friendly. So Portland's joined the global network of age-friendly cities and communities. Multnomah County's now formally joined that network. Springfield has joined the network. Why can't the whole state of Oregon join as a whole in the age-friendly network?
And our last panelist is Derenda Schubert. She's the executive director of Bridge Meadows, which is a foster grandparent volunteer station, so I want to thank you for that. Derenda also serves as a commissioner on the Oregon Volunteers, which is the AmeriCorps State Service Commission. Dr. Derenda Schubert is a licensed psychologist with extensive professional experience counseling children and families and creating, managing, and evaluating foster care, mental health, and developmental disability programs in Chicago and Portland. She has served as the Chief Operating Officer of the Trillium Family Services and is a board member of Bridge Meadows. Dr. Schubert is an intergenerational champion, advocating nationally for intergenerational solutions to complex social challenges, leading the team that created Bridge Meadows and the strategic planning process to shape Bridge Meadows' expansive vision for the future. Bridge Meadows received a national recognition by the National Home Builders Association, named an Angel of Adoption by Senator Wyden, and was a 2014 award winner for the Intergenerational Excellence Prize by the Eisner Foundation. Dr. Schubert is a graduate of Purdue University and received her doctorate from DePaul University in Chicago, Illinois. Dr. Schubert's passion for making the world better for children, families, and elders, and the power of community is inspired by her own children and the love of their grandmothers. Thank you.
Hello, everybody. Nice to be here today. And I want to give a special shout out to all the Bridge Meadows groupies in the audience today. I know, look at you all. You're all very special part of Bridge Meadows. And for those of you who are not groupies yet, hang in there. I know I'm the only thing between you and a break, so hang in there. Because I'm going to tell you about some great healthy living and aging that happens in a Bridge Meadows community. So Bridge Meadows was created for the purpose of helping children become adopted from the foster care system, supporting their families to thrive, and then providing the secret sauce, meaning and purpose for our elders. When an elder lives at Bridge Meadows, they are given an opportunity to volunteer in the lives of children and the parents and with one another. When we introduce an elder to Bridge Meadows, we ask them, what are the gifts and treasures you'd like to share with the world? What brings you joy? What is it you've wanted to do that you've not been able to do that you'd like to share with this community? And they look at us like, really? You want me to do that? And we're like, yes, absolutely. So all the elders have the requirement to volunteer 100 hours a quarter. Although what they would say to me is, Derenda, it's really voluntold because it's part of our lease. I'm like, okay, thank you. But it's about community engagement. It's about connecting and belonging and knowing that you are important in the lives of others. So the elders volunteer in many, many ways. As Dr. Tan said, they are volunteers with the schools through a foster care and parent program, but they're also providing significant hours of child care for the parents at Bridge Meadows, helping save child care costs for the parents. They're providing chauffeuring duties. Imagine a single mom with 3 kids who are all actively involved in soccer, cheerleading, and baseball. How do you get them all to practice at the same exact time? Well, the elders help out with that. They also support one another by going to the doctor, being a shoulder to cry on. And when a child from Bridge Meadows has an activity at school, it's the paparazzi showing up. You know a Bridge Meadows kid because there's all the elders with their cameras. And these are children who thought that they were thrown away and weren't worthy anymore. And now they have an entire community to love them and to support them. The elders also receive services because they are our treasure, and we will treasure them. They receive medical services, diabetic care. It comes to the office. And Carol, we had a dental van a couple of weeks ago because we know that we need to help keep them healthy. The impact on their lives has been that they are living vital, incredible lives where they thought that they were invisible and not worthy, just like the children. They now feel as though they are important and their skills and gifts given to the world. I love to be in the community room and watch a little one run from one end of the room to an elder and run quickly yelling the elder's name and grab onto the leg. That is a beautiful moment that brings me to tears on a regular basis at our office. The elders are also experiencing significant health impact. Our elders are reporting their doctors are stating their blood pressure is reducing. They're living through cancer in a more healthy way, if that's possible, and longer. We've had an elder report to us that her doctor said, you look better than your cohorts living with cancer. And I think it's because of all of those kids that you have. We also offered to this elder that she might want to take a break from volunteering as she went through chemo, and she got angry with us. She said, don't you think I can do it? I'm like, oh gosh, we were just trying to be nice, sorry. Okay, forgive us. They also feel as though they belong, which is so important. They felt adrift and that they were put out to pasture, and don't we all just want to feel like we belong? I'm going to leave you, because I'm getting the 2-minute thing there, with a story. One of our elders came to us and told the story. She said, before I lived at Bridge Meadows, my mind was like a tight rosebud. And as I've lived here and gotten to be a part of the children's lives and the parents' lives and shared my gifts and talents with this community and been embraced for those gifts and talents, the petals have slowly opened little by little. And now I feel like I have fully bloomed. Thank you.
I want to really thank all our panelists. I've personally learned a lot from just listening to all of you, and I'm sure all of you in the audience have as well. Unfortunately, we are running short on time, so if you have questions, please save them, and they can be part of the discussion at our breakout sessions later on today. I want to thank the sponsors. It's been a great conversation. And I also want to thank all of you in the audience for being here today on this important issue. Okay.
Thank you, everybody. So the plan is that each of you is going to take 3.50 minutes to briefly describe the group's issues and recommendations. So I don't care what order we go in. So anybody ready to start? We have elder justice, healthy aging, long-term services and supports, and retirement security, but that one does need to be last. Are you ready, Fred?
Yeah, I'll jump right there.
Okay.
So I am only ready because my group was awesome that I got to work with. So great conversations in our subgroups. And where we were at with recommendations, we started off looking at the 2014 Elder Justice Coordinating Council recommendations that came out at the federal level. And somebody brought that to the table. Ellen Clem, not surprisingly, brought that to the table as a starting point for our conversation, just to kind of help us think through what the feds are looking at. With the subgroup conversations and then our ensuing 45-minute full group conversation, I think really what, 3 of the 4 recommendations are things that need to and can be focused. And this is definitely our Oregon recommendation to the feds in the national level, the White House, of what can be accomplished or needs to be accomplished. I mean, all 4 of them are for the national level. And then 3 of the 4 are things that can be looked at internally in states, either whether it's through legislative action, Governor's Commission on Senior Services, or different county and state approaches. So the first one, and this one very specific at the national level, is the need for more national coordination on elder justice issues and elder abuse. There has been recently, just in October, a renaming of an office at the Administration for Community Living. They renamed the Elder Rights Office, the Elder Justice and Adult Protective Services Office. But as Marie Cervantes confirmed for me, or at least as far as she's aware, there's been no communication from that office as far as what national coordination is going to look like. But I think in the national level, I mean, and I'm even aware, I work with that office. It was a first step to rename it, to have a central location for issues of elder justice and adult protective services. But I'm aware that at least for the last year or so, they don't have a director of that office. They're in the process of hiring one now. From even what it was named previously. So there's just a lot of work to be done at the national level. And for our purposes, and I need to go back and look at my notes for our full recommendation, but it's the need for the data coordination and collection, the awareness. Just a lot of the research that needs to be done. There needs to be a lot more national coordination. So I'm going to put a lot more meat onto that for the products coming out of today. Secondly, a public awareness campaign, and this is definitely one that can and should be done at the national level and can be done at the state level. And we need to spend a lot more time looking at all abuse types was emphasized in our work group. There was some emphasis in some of the smaller groups on financial exploitation in particular, and because of the costs of financial exploitation, more awareness, more education. But the larger group that we had wanted to make sure that we were emphasizing all abuse types, sexual, physical, emotional, psychological abuse as well. An emphasis we can start moving towards, or we should start moving towards some kind of a marketing campaign. And then as a component of that, enhanced supports for victims, and ideally before people become victims, more supports, more resources, infrastructure. So there's a lot of work to be done around there. And again, a lot more even meat than that on that public awareness recommendation. Third is around law enforcement supports. Actually, I'm realizing there actually was 5. So law enforcement supports reconsiderations. We had some conversation, again, not only at the local level, what better tools can we be providing to our law enforcement to get involved in elder abuse situations that are even arguably, and in some instances, out of the hands of what adult protective services can do. We need more considerations, but definitely at the federal level as well, with the FBI, their Department of Justice at the federal level. So that would be a third recommendation. Fourth recommendation is around fiduciary reforms, fiduciary education, so guardianship, conservatorship, powers of attorney, rep payee. We had some conversations specifically around that. Definitely a recommendation at the federal level with Social Security Administration. And I am aware of some activity in that department with Social Security Administration in a subgroup that I've had the privilege of being a part of in the last 6-8 months. But there's much further to go there. A fifth recommendation specifically around, and this wasn't an initial recommendation out of the subgroups, but in the ensuing conversation of our full group really took form. But more, what I'm kind of framing is community approach supports. Around more not just multidisciplinary teams that do exist at the county levels, but more, this interdisciplinary approach to prevention issues. I would categorize our conversations and there was some conversation around, bringing in community health approaches and entities to have some conversations about how we can better really do the proactive prevention of elder abuse. So I will stop there. I'm probably over my time already. Thank you.
All right. Well, not that it's a competition, but the healthy aging people rocked too. and came up with 3 excellent issues. And what they did really well was bundle. We were a bundling group. So I think everyone sees themselves reflected in these. So if we were to look at age-friendly communities, which is also building a community for all ages, it was really clear that this is intergenerational and multi-sectoral approach, but using that age-friendly foundation and infrastructure. Looking to meet the needs of Oregon's diverse communities, really recognizing that a county is a county and no county is alike, that uniqueness that comes to Oregon. And then thinking about what we would need as higher leadership support and leadership support in general as this movement builds from cities, counties, up to the state, but really having the governor endorse this and see this as a vision and a goal. It's aspirational and inspirational, but we know how to do it and we can do it. There's an infrastructure to follow. So getting that commitment from the governor, potentially having a commission, an age-friendly communities commission or communities for all ages commission, having a policy advisor who focuses on to the governor for healthy aging and age-friendly communities. Really looking for that outreach and that communication strategy. So how do we increase awareness and really have people thinking about the importance and what it means to age well in this state and starting that early on. And having a very strong commitment to empowerment. It was really important that communities have the ability to mobilize and empower themselves to identify their priorities, but even more so, really honoring the independent living and the importance of people to be able to engage in their own health and make their own decisions and be part of that instead of being told what to do. So that commitment to that authentic communication and to build trust to make that happen. Recognizing that there's a lack of trust out there maybe in some of the service agencies that are providers and those who are the end users. The second issue is looking to an integrated and comprehensive services that are reimbursed by Medicaid and Medicare. So that kind of captures both the problem and the goal and the solution. But really recognizing that mental health, dental health, physical health, and a long list that we came up with, that we get out of our silos and that we come around true patient-centeredness, which would really mean having multiple care providers in contact and working with each other to help successful optimal health happen for our patients and our community members. So moving out of our siloed sectors, looking at interdisciplinary care and learning. So what does that look like from a medical education perspective? How do we train that earlier on? Again, more community awareness. I think that has really come out loud and clear, and I just heard it in the prior session, is that there needs to be a lot more talking and a lot more broad communication strategies to get conversations happening in people's homes. And then more research and understanding what the data can do, collecting more data and doing more research around how we age and causes of disability. And the last issue, while it kind of is part of those other 2 issues, but was really important that the group didn't want to lose sight of, is just mental health in general for all of us as we age and how that doesn't get lost, that it's really called out and such a key piece of what we need to do so that it is integrated into our care and that it's not seen as a negative, that people aren't afraid to talk about it. And this was also really important for caregivers and caregiver health and what that means to take care of those who are taking care of us. So that's the high-level summary. Thank you.
Well, our group on long-term care was a group that rocks too. Unfortunately, they had a rock for a facilitator. And I cannot find where our sheets were, which I was going to go to. But there were several things that really did come out. And first was every group picked transportation as one of their issues. And the thing that really came out on transportation was that it isn't simply medical and getting people to a particular service. It's about the social aspect. And the way I like to put it is, we haven't moved that far if we've moved from warehousing seniors to putting them in storage units. where they're not connected with the community, and people want to be connected. So we need to do that. And that transportation itself was a socialization aspect for people, as well as a mental health deal in terms of just getting out of their place, and we needed to take it. And of course, funding is you just can't get around it. It's a key issue around transportation. But there also is a need for better coordination of all of the transportation assets within a community. That we need to look at how we have a central hub where you can find information and where the different resources can be used across programs and across ages where possible. And then finally, that there needs to be safety taken into account in terms of it, and talking about public transportation where seniors often don't feel safe within that, but also just training those drivers and stuff to be sensitive to the needs of the individuals that they're working. The other were two around culture. One was culture change, which was spoken up this morning, and that is that we change the concept that aging is an asset, not a problem within our culture, and looking at that. And some of the sort of solutions were things such as age-friendly communities. In other words, don't talk about simply making it accessible for seniors, making it a community that's accessible for people at all ages. We don't need that dichotomy, because things that work for seniors also work for young parents with kids and a stroller or a bicycle or something, that the similar types of concerns are there. And then talking about intergenerational coordination around assets. In other words, building programs where we use the assets of the seniors, which may be wisdom, may be the caring, the knowledge they have, around that of younger people, which may be the physical ability to do things. And looking at how we build that. The one caution was, not all older people want to be around younger people. So recognizing the fact that, this is individual. The other cultural was the whole idea of making our services culturally responsible. And we were lucky enough in our group to have some participants from the deaf culture. And often that is a culture that is ignored when we are looking at serving people. And so they brought some good points about that, that we need to look at each. And once again, it gets around being person-centered. Each individual is different. But service providers need to be aware of the culture of that person and how that might affect the situation. So there needs to be training around this awareness of cultures and how to deal with. The other thing that came out was it's just like transportation. It's been an issue from the beginning. We discussed it the first White House conference that I was at. We're discussing it again. And that is better information on services. That there's still, even with our ADRCs and stuff, our problem. Some of the individuals went to it around deaf services. Most of the deaf services they found on our ADRC or on the website were in New York, not in Oregon. And yet they were aware from their information referral of a lot of services that were available. So we need to go across our various databases and see how we get to them. And then we need to ask, especially our various subpopulations, let's look at the service, our information and referral. Is it working for you? What isn't working? Are you aware of other services and stuff? And let's see, person-centered was the other big thing. And that really crossed a lot of barriers and actually came around in each of our other discussions. The fact that we need to one, take into account the cultures of the different individuals. Two, that we need to be training our caregivers, but not just the caregivers, people throughout our spectrum about the various cultures, so that they're even aware that there are issues. And one, I think, interesting one was the whole issue about caregivers and caregivers following the person from setting to setting. Because one of the big issues for individuals, and I think that's especially the case for people who feel very vulnerable, is the trust building. And so having somebody who you've learned to trust go with you to the next setting to help, maybe not do all the care there, but help you in that setting, is a real key issue to people. So those were the main ones, and we had a lot of ideas, a lot of good ideas, I think, and it's going to be a real experience, I think, for state staff to look at those, because I think there were some very specific types of things that will be helpful.
Thanks, Don.
Hi, everyone. Good evening. Okay, so first I'm going to report out on our retirement security breakout, and then I have some closing remarks on behalf of the department. So I'll start with our breakout, which I think was also just an amazing group of people. We came up with quite a few recommendations, and I'm going to try to go really, really fast so that I can tell you what all of them were, because I don't want to leave them out. So the issues that came up most prominently were around Social Security, the adequacy of benefits currently, and then how to expand and protect SSI, and also the retirement and disability programs within Social Security. And then also related is the fiscal health overall of all of those programs. The second issue was the lack of financial education in general, cost of living in general, the issues around family caregiving, and the overall lack of savings and the fact that we need to rebuild the three-legged stool. So our recommendations within Social Security, there were a number of recommendations. So to address the fiscal health of the programs, or at least part of the program, we talked about removing the earnings cap, so on the payroll tax. So you would get rid of that, which would increase the longevity of the program and the sustainability of the trust fund. And then we would increase all benefits, SSI and the retirement and disability side, to at least, and this was the very minimum, was 120% of federal poverty. And then also we had consensus, I'll just say, around all of these recommendations. There were a couple that we didn't reach total consensus on, but these were the consensus of the group. We would use the Consumer Price Index for the elderly to calculate the cost of living adjustment, or the COLA, so that it was a truer reflection of the expenditures for older adults. So their cost of living increase would reflect their expenditures. The second recommendation is around positive media attention about retirement security in general, and that can be done through all different forms of media, but we really thought that that would be something that needs to happen right away. Also, fiscal education and awareness and continuing education, starting in schools and then moving beyond. So throughout the lifespan, we would continue the conversation and the education. And a couple different ways of doing that were recommended. One would be to have an evidence-based pilot that would, be a pilot around education. And it would be a long pilot, because you'd want to measure over a long period of time whether you were successful or not at educating people about retirement security. And then also, it was raised that an intergenerational approach is effective. One of the stories in our group was about how when individuals are younger, maybe they don't understand why some of their earnings essentially are put into a plan that they would use later, and they wanted that in their paycheck immediately. And the older people in the workforce were able to say, no, trust me, you're going to need that. And so having that sort of intergenerational connection about what you need when you're older would be important in educating our youth about retirement security. Then we should address wage inequality, or eliminate, we came up with a more strong word at the end there that we had consensus around. So eliminate wage inequality. And some of the sub-issues are around gender disparities for people of color. We would address age discrimination or elder discrimination, and then make sure there's increased employment opportunities for older adults. Support the opt-out retirement plan discussed today by Ted Wheeler. Rebuild defined benefit plans and strengthen both defined benefit and defined contribution plans. A couple of ways to do that are to take away incentives that encourage conversion of a defined benefit plan to a defined contribution plan. Make plans a little more portable, like they've done in Canada. Encourage really long-term savings, and look at penalties within defined contribution plans to see if they really deter people from cashing out. Because I think in our group there was some indication that, or evidence around the fact that some of those penalties, like the 10% penalty, really doesn't disincentivize people from cashing out, and make sure people understand the value of staying in tax-advantaged plans. Then we would create more innovative ways to save. So thinking about things like an app that would go on your phone and automatically a certain amount of change you might have go straight into a retirement savings plan, as long as there were the appropriate protections in place around the new technology. Address housing. So we endorsed this statement. We had consensus around the statement, housing as a human right, in our group. And then also national action around increased revenue, where all entities pay their fair share. And we would look at a new way of budgeting so that we're capturing future savings related to current expenditures and investments. So those were our 10 consensus recommendations. Thank you. Thanks for everyone who participated. So I'm just going to take a couple of minutes. I want to thank all of you on behalf of the Department of Human Services Aging and People with Disabilities program. Our director, Mike McCormick, really wanted to be here to thank you at the end of the day, but because it's legislative session, he did get pulled back to Salem for some legislative responsibilities, but he was here all morning, got to hear all the great panel presentations and our keynote presentations. He really sends his best, and he was really happy to see such a packed room here today. Both Mike and myself, we really look forward to the recommendations from all of these breakout sessions, the panels, the speakers. We want to work with you in an ongoing fashion, and other stakeholders, the legislature, anyone who wants to get involved, so that we continue to be able to have the right types of programs and policies for older adults and people with disabilities in Oregon. And I also want to say thank you so much to Judy Strand and the Governor's Commission, the entire Governor's Commission on Senior Services. So if some of you, I think some of you are still in the room, if you could stand up, I'd like to recognize all of your support. Thank you. So we wouldn't have been able to have an Oregon version of the White House Conference on Aging without the wonderful Governor's Commission. So thank you so much. And last but certainly not least, I want to thank all of our extremely dedicated staff at Aging and People with Disabilities at the state. In particular, Ann McQueen has been our tireless conference planner and advocate. And then she's had all of these other staff and volunteers around to help today. And so if you could all stand up, just want to recognize you and thank you. And I think that's all I have. So thanks so much for being here. And I'm going to turn it back to Judy.
Thanks, Ashley. Okay, such a great job. I'm so proud of all of you. And what we're going to do is to work with the facilitators. Staff are going to pull things together and have a tight report that will go to DC. And I'd like to just say from the commission standpoint, we're going to use these ideas for our state work too, from a commission advocacy perspective. So this is just like a dream come true for us. And in light of that, one of our struggles has always been to get statewide representation to feed ideas to the commission. And so a couple of you suggested that we see who's here from different parts of the state. And I realize some people have left, but could you stand or wave if you're on the I-5 corridor? Okay. Southern Oregon. Yeah. Central Oregon. Okay. Eastern Oregon. Okay, we're gonna have to go there for the next. Oh yeah, there they are in the corner. Okay. And how about the coast? Okay, great. Well, that's really good to know. We'll probably know more from your registration too, so we can figure that out a little bit. And the other thing I wanted to say is that you'll get the information sent to you there if you gave us your email. So you'll get to see all the recommendations that you just heard. And then these are my notes from Anne. I'm supposed to tell you to wear those buttons. There's buttons on your table, and it says, "Ask me about the White House Conference on Aging." And that's so you can share what we've done. And then also to remind you to do the purple evaluation sheets, please. We need feedback. And if any of you are interested in the tour of the veterans facility that we heard about, there's some people meeting at 4:45, and you can get a tour right away. And then just before we go, I do have something for Anne. Anne needs to come up here. Okay, this has been very hard to hide, but this is thanks to this. So this is from the commission, and we thank you for your incredible work, man. Thank you. I mean, I'm telling you, this woman has not had a lot of sleep, so we need to be very kind to her. She's put her all into it, and it wouldn't have happened without her, so. All right, I think we're done, and I feel very inspired. I thank all the speakers, the panelists, the facilitators, the sponsors and contributors, the planning committee, the volunteers, and mostly I thank all of you for being here, and I'm really, really happy with the results. So bye for now. Samaritan Health and the Conference Center staff, the Medicaid Long-Term Care Quality and Reimbursement Advisory Council, AARP Oregon, the Oregon Department of Veterans Affairs, the Oregon Association of Area Agencies on Aging, CCTV Salem, Albany Volunteer Caregivers, and our fantastic conference planning committee.
Here in Salem as much as I can,
every
because
American
Salem
would
is my
want,
home
which
base.
is a little common sense government.
American, young, old, rich, poor,